Thank you. Thanks for having me. Thanks for this opportunity to share with you a lot of the work that we've done. This is a smattering of things that we've done over the years, so not intended to be a complete view of everything that we've done. All of the talks this morning sort of inspired me to change what I'm going to say a little bit, so some of the slides might be a little bit off, but there's such a rich discussion to be had here, and the depth and breadth of the presentations today are just really inspiring. Just in case I don't remember to do it at the end, I want to recognize that there are many, many people who've been involved in our work over the years. This work that I'm going to talk about covers almost 25 years of collaboration amongst multiple disciplines. So engineers, physicians, nurses, biomedical engineers, systems engineers, human factors engineers, physicians, and not just nurses who are bedside nurses, but all different types of nursing participants. And I do have a relationship with Massimo to deliver talks like this as a consultant, just so you're aware of that. For those of you that don't know, Dartmouth Hitchcock is a hospital that's about 400 beds located in rural New Hampshire. We have a very high CMI, top 20%. Ooh, I didn't forward. There you go. Thanks. Thanks for that heads up earlier. So Dartmouth Hitchcock is a rural hospital, very high CMI, top 20% amongst academic medical centers, the top 5% in the nation, and we have very high occupancy. We have the largest number of Medicaid and Medicare patients in the state of New Hampshire. We also draw patients from the state of Vermont as well, so we're a pretty busy place, lots of surgical specialties, and many medicine patients as well. So this particular work was initiated by this event. We had a patient in their 30s, that was brought in for a routine medical procedure. It was a surgical procedure. They had been assessed prior to that surgery, and after the surgery were in the inpatient unit. They had opioids and were given additional medications for anxiety, and they were found dead in bed. And my colleague, George Blake, who was then patient safety officer at Dartmouth Hitchcock, who I had been working with for several years on remote triage work, unrelated to in-hospital work, called me and said, you need to come over here. We need to take a lot of the ideas that we've been developing for remote triage and bring them into the hospital. We can't ever have this happen again. This is something that we just won't tolerate. And so that really has started since that time. All of the work that I'm about to show you that spans, that was about 2006. And so from that time to now, so it's nearly 20 years, but we were collaborating for many years before that. So this should be a familiar case to you, right? So this is something I'm sure all of you have heard about, but what should never happen in any hospital anywhere. This is a totally preventable event. So Dartmouth Hitchcock made this commitment not only to reduce opioid-related deaths, but unwitnessed arrests totally. So it started with the patient who was on opioids and quickly expanded. And so we sought to develop a system. We didn't buy a monitor and install it. We developed a system with processes, with evaluation, with measurement that we implemented with bedside monitoring using pulse oximetry on all patients all the time. So at that time, we elected to use pulse oximetry because we felt that it gave us multiple parameters with one sensor that we thought would have high patient acceptance, which turned out to be true. And we decided to monitor all patients all the time because risk prediction systems would not have detected, given high risk to that patient that died. And so we felt that there was no really good way to ensure that we would not have another case like the one that brought us to this place. And so we monitor all patients, their entire general care stay, medicine and surgical patients. I highlighted the word surveillance there because the system, we were not the first to try to do continuous monitoring in the inpatient setting, but we were the first probably to think about it as a system and to bring in a human factors engineer to figure out how we could make this system so that it was a partner to the nurses. This was not an extra thing for nurses to do. This was something that was introduced as a collaborative system. This was intended to be technology that was serving the nurses at the bedside who have a high nurse-patient ratio. And the intention here was to draw attention to severe and sustained deteriorations. And I I think that's really important to understand. This is not multi-parameter monitoring where we're alarming all the time on SpO2 of less than 90. This is supposed to say to a nurse who's busy with Bob, Elizabeth needs you now. You need to come now. There's a serious thing going on here. And the only way that we figured that we could have nurses participate and manage those alarms was to have very wide alarm parameters. So we alarm at an SpO2 of 80, and then on pulse rate it's 40 and 50 and 140, and we've subsequently reduced it to 40 beats per minute is our pulse rate low. We also introduced an alarm delay before we get to an audible alarm. So if you hear an audible alarm, the SpO2 has been below 80 for 15 seconds. And then we use directed notification. If you are the nurse responsible for that patient, you are the first. We use pagers, so I'm going like this to illustrate pagers. But now we're using phones, which are probably still right here. And so it's directed notification, so it's not broadcast to the entire unit. We don't have every nurse getting every page, and the alarms are actually turned down because we have pods, and so only the nurses in that area should really be hearing those audible alarms. So all of these things were designed. This was a system that was created intentionally. And we piloted that system in a single unit, orthopedic unit, and did leadership rounding, and were there daily. The vendor was there daily. We were collecting data all the time. We were changing settings as needed based on the feedback that we got from the nurses. And then the system was rolled out after everybody was comfortable with it, and the nurses felt like the number of alarms was something that they could manage. And so I just, again, want to emphasize that this was a system that was designed very carefully for this particular setting to solve this particular problem. We also, over the next few years, developed a roadmap where we saw what we had done in the inpatient setting, that the data that we were collecting and starting to process and report on could be used to develop systems at multiple levels. And so over the years, we had an ARC P30 looking at failure to rescue from 2015 to 2019 that was based on the idea of taking it from the floors with threshold alarms and then creating a whole suite of tools that could be used by nurses at the bedside, and then using sort of a command center way of thinking about things so that we could do resource allocation of our rescue teams. We could move flex nurses to units where there was higher acuity patients at certain times, and also activate those rescues if we needed to. And then, of course, you can see where that's going, from one site to multiple sites to the at-home environment. And we really still believe that the data set that we've collected is very informative for moving into a home setting and trying to detect events that happen there. Okay, so what's the data? So we have continuous monitoring data collected every second from every patient that we've monitored since 2007. We have a massive Oracle database. Bless our IT people for doing this for us. It is part of the medical record. We have 220 plus beds that are on this system. So we're constantly collecting this data. It's probably close to 500,000 inpatient visits, which is somewhere on the order of 2 million patient days, something like that, that we have. We are able to marry that data with the electronic health record. So it's time synchronized, so we can line things up. So we can line up when a patient landed on the floor, when they were admitted to the system, when they were transferred to a higher level of care, when they came back. We know all their diagnosis codes. We know when orders were placed. And so if you see an order for lactate, we can time sync that with a physiologic record, continuous physiologic record of that particular patient. We also integrate vital signs that go into the medical record as well that aren't collected continuously. We also have several things that we calculate, Charlson and case mix indices for each patient, and state scores, NEWS, NEWS2, QSOFA, and MUSE. These are calculated retrospectively using methods that we've developed for missing data and old data. And we also have, of course, access to our rescue databases so that we know if there was a rescue, we know what the disposition was, we know if Narcan was administered, and so on and so forth. So we think we can form a pretty good picture of what's going on with the patient in the inpatient setting with this. So we've used this for a lot of different purposes. First and foremost, back in 2007 when it was implemented, the question, and you heard them this morning, can we afford this and is it going to do anything for us? And so our early papers were really focused on saying, yes, we can save money by doing this, and yes, we can reduce transfers to higher levels of care and also reduce rescues. And so our leadership was convinced based on that to roll it out to the rest of the surgical and medicine units, and that's how we got full system implementation. We also use this as the black box from an airline that was referenced this morning. So if we have a patient safety event that happens, we immediately get a request to provide the second-by-second data matched up with the other data to provide back to the floor so that there can be a review of what happened with that patient and how that deterioration could have been caught earlier, or what can we do better, and what went right, how was it that we were able to rescue that patient, and what were those patterns. We have a dashboard for quality assurance and safety that we show that I'll give an example of in a little while. And we also do research. There are so many things that we've done where we've had unexpected results where we go, wow, would you look at that? How about if we do this? And what if we added this or did it this way? And so there's been a lot of innovation that has come from the very boring act of measuring the system to justify in its existence and to maintain system performance over time. So we've just gotten a lot out of being able to measure things with our system. So the pilot performance impact was referenced this morning a little bit differently than it's shown here. We had a 48% reduction in transfers to higher levels of care and a 65% reduction in rescue activity. That was, again, an orthopedic unit versus 2 units that did not have the system implemented. I think the p-value on those was 0.01. So fairly good differences in that unit where there was absolutely no difference in the other units. We also showed, we did 2 financial analysis with 2 slightly different results with the approaches, but saved somewhere in the order of $1 million per unit. That's a 36-bed unit opportunity cost based on that transfers to higher level of care. Alarm rates 2 to 4 per patient per 12-hour shift, well below what we would consider alarm fatigue. Even now when we have other alarms like bed alarms added in, it's still a manageable situation. We're still just about at that number. A later study that I did showed that about 85% of all the alarm conditions are resolved within 30 seconds and 99 before there's escalation triggered to the pager or phone. What we were seeing a lot of is nurses coming into the room to help the patient and not silencing the system, putting it in standby prior to taking the sensor off. And so many of our alarms have to do with people adhering to the way that they put the system together. And I say they, I mean nurses help to design the system, so it's their process. Oh my goodness, I'm not going to be able to show it. Okay, so that slide, which does not show all of our control charts for our system. And so I apologize for that, but what it should show you is that we instituted a dashboard where we measured all of the things having to do with the system: rescues, transfers to higher level of care, utilization, different kinds of rescues, so separating out codes, stat airways, hurt calls, and all those things. And we tracked them over time, and we were able to show that the system was performing pretty steadily. Even 10 years later, we were getting essentially the same results that we had gotten in 2007, and that the CMI of our patients had gone up significantly during that period of time. We had also had the loss of a lot of experienced nurses, so we had a lot of lack of experience. So we were very pleased to see that some of the system numbers were holding fast during that period of time. My apologies for that. So in addition to, so we didn't do mortality in our original work because those deaths are fairly rare, right? So But 10 years after we implemented the system, we decided to do a look back and see if the patient that had started all of this, who had died from the opioid overdose, would have been saved. Did we meet that mission of never having another patient die of an opioid overdose in the inpatient setting? And the short answer to that is yes. So in 10 years on monitored patients, we had 0 deaths that were opioid related. We had 0 patients that had harm. During that same period of time, we had 3 deaths in unmonitored units. And the reason that we had that is it was during a rollout period. So not every unit had the system in place. And so all the deaths during that 10 years happened in units where we did not have monitoring in place. We had 1 death in a unit where monitoring was available, but the monitoring was not being used at that time. So I'll also comment that patients can, of course, refuse to be monitored. And so we have a way of dealing with that and really encourage people, nurses, they have a script that they can provide to the patients to really encourage them to be monitored, but not every patient is monitored. So this is just remarkable to me. And so discussions of randomized controlled trials and all the things that would prevent us from doing this, to me, a hospital that had 0 deaths over 10 years should be enough evidence for every hospital in the whole United States to adopt continuous monitoring carefully. The other thing I'll say about cost while I'm at it is that we didn't know that we were going to have a reduced number of transfers to higher level of care. So when the system was implemented at Dartmouth Hitchcock, the money that was used to buy it came from a reduction in inappropriate ordering of telemetry of patients in the general care setting. And so when we were not the only ones to do that, Ohio State had a 53% reduction in telemetry orders. I read another paper I browsed this morning had a 43% reduction. So if you have appropriate ordering of telemetry, those very much more expensive systems, you can have less of them, and that money can go towards continuous monitoring of all patients. And so there are ways to address that cost issue other than the transfers, the opportunity cost and transfers to higher level of care. Okay, on we go. I think I was already at the next slide. Okay, so over the years, we've upgraded the system. So we now use something called Radius PPG. So it's a wireless monitoring system, goes to the finger. At one point, we were using a Radius that was on an armband. We also implemented the Root system where you can see trends at the bedside. So the more information that can be seen right at the bedside, we think the better. We'd already published a paper that showed that hand-entered data, vital signs, is often wrong. I think we estimated or calculated a 6% higher SpO2 value when recorded by hand versus the actual value that was recorded by the device at the time. And so ADT integration, the ability to get accurate information into the medical record, and also to be able to collect vital signs very quickly. This was a huge win for our nursing staff. We were able to save hours in terms of vital signs data collection, more utilization time with the wireless system, less risk of entanglement and all of those things. So this was an upgrade that we did starting in 2015. Okay, so another one that you can't see, it's that result, so that's fine. I'm relieved. Okay, so now moving away from looking at things like patient days and rescues and transfers to higher level of care, so things that we do in the thousands to things that we do in the billions and the trillions. So this is analysis of the physiologic data that we collect second by second. One of the earliest things that we did, this was my student Josh Pike did this work for us, looking at the distribution of SpO2 and pulse rate in the general care setting. I also call this, I have it listed as a change management slide because we had a lot of pushback when we went to move from the surgical side of the house to the medical side of the house. We kept hearing, my patients are different. They don't have the same physiology. They don't have the same number of rescues. We don't need this system. And we were able to show with the data after we implemented on the medicine side that they're identical. There's no real difference between the physiology in either sets of those patients. They have the same number of rescues. In fact, at that time, our medicine side of the house was having more rescues than the surgical side of the house. I tried to list the number of patient days and points so you could see, because this is a big data presentation. Here's another system study that we did. So we were often asked the question, why didn't you look at respiratory rate instead of pulse oximetry? And we wanted to answer that question, and so we implemented a acoustic respiratory rate monitor in several units over a number of months and collected the data. So first we collected it in the background with no alarms, and then we used that data and plotted it and did a simulation of the number of alarms we would have at each alarm threshold so that we could appropriately choose the alarm thresholds for respiratory rate. And so that's a real use of data where we're not just picking things out of the air, and we were able to add that alarm to the system without increasing the overall alarm rate by more than, I think it was 1 alarm per patient per 12-hour shift. We also use the same system to try to understand if we should add respiratory rate to our surveillance system. And just as a reminder, the surveillance system is intended to bring you to the bedside immediately when something very bad is happening. And so we looked at whether or not we could get more bang for our buck by switching to the acoustic respiratory rate sensor rather than pulse oximetry. So we compared values of the two things, and I think this was over 1 billion data points that we looked at. The respiratory rate sensor worked and has since been improved dramatically, and you heard a lot about different wearables. So that technology is there, usable, ready to go. But for the purposes of bringing attention to the bedside and adding another sensor or swapping out the pulse oximetry, we decided that for us, the right thing to do was to continue to alarm on pulse oximetry. So this is not to say that you shouldn't also measure respiratory rate. It's to say for us, for surveillance, for that purpose, we chose to stay with the single sensor that was very well adopted by our patients. The staff knew how to use it, and we were getting very good results with that system. Another question that we've been asked over the years is whether or not you can safely monitor patients who are on oxygen using pulse oximetry. And in theory, patients who are on O2 may drop off more quickly, and that rate of decline once they start to deteriorate could be a concern that you might not get there in time to rescue that person. But up until the point of this study, we just didn't see that in practice. And so we hear it, we heard people talking about it, so we wanted to try to explore it and see if we could detect this in our population. And the answer is we could not. And so we were able to see that patients who are on oxygen have higher mean oxygen levels, which, as you would expect. And if analyzing their desaturations, as shown in the top right-hand picture, the group that was on room air had more desaturations, an average more time spent in a desaturated state than the patients who were on oxygen. And of course, in the other states that we called recovery and normal, those numbers were different according to that higher percentage in desaturation. So when we look then at the characteristics of those desaturations, so the magnitude, the duration, and the slope, to see if there was a difference between patients on O2 and on room air, we did not see a difference between those two groups of patients. This past year, we decided to take a better look at this. And so now we're looking at almost 6 years of data. It's 120,000 patients, so that's somewhere 700,000 patient days of data. And what we've done is try to detect whether or not there are signs of late recognition for those patients. So are we getting there too late to rescue those patients? And we don't have all the statistics quite done, so I'm reporting some preliminary data here. But I can tell you that patients that are on oxygen in this cohort of almost 6 years do not have higher rates of rescue, especially the more serious rescues, so stat airways and codes. We don't see that those patients have higher rates. We also defined a planned and an unplanned transfer to higher level of care, because you can call a rapid response team without the patient really meeting the criteria of a rapid response team. So we didn't want to say that if someone had a rescue, that they didn't meet certain criteria. So we looked to these types of transfers to sort of really understand whether the transfer was one that was planned or unplanned. Was it an emergency that had to be undertaken, even if there was just a life safety consult, which is a consultation at the bedside. So we found that those patients on supplemental oxygen did not have higher rates of those unplanned transfers than those that are on room air or transfers in general. So it looks to be that we're not harming patients who are on oxygen by monitoring them with surveillance. We are able to rescue those patients when needed, just as well as we can patients who are on room air. Also, deaths, not higher rates of death after rescue either. More on this later, not today, but we're also going to go back and do the desaturation calculations on this much larger cohort as well. All right, so one of the questions that we get asked all the time is, how can you possibly use an SpO2 low of 80 for your system? That's unconscionable. And so again, this is for surveillance. So this is the come now sort of arrangement. And there's a balance here between alarm management and having nurses feel like it's not a burden and that there's something actionable to do at the bedside, versus having too many alarms and that, you know, you can detect deterioration perhaps earlier, but there's going to be a lot of alarm fatigue and people just not coming to the bedside at all. So we did a study looking at retrospectively what number of alarms you would have had if you had used various thresholds and enunciation delays for pulse oximetry, so both SpO2 and pulse rate. And you can see in the top right-hand corner these dramatic drops, right? So each one of the colored lines represents a different threshold for the parameter, and then as you go across from left to right, it's the delay in enunciation. And so if you're looking for severe sustained deteriorations, you're down the bottom and going to the right. And we compared the impact on nurses using surveillance monitoring configuration to the two other configurations that we use in our hospital, which are condition monitoring, which is when you have someone that's a known risk and you want to more closely monitor them, and also critical care monitoring. And you can see the dramatic uptick in the number of pages and escalations and alarms that that nurse would be exposed to with those other configurations. And so we believe strongly that continuous monitoring should be in place for all patients all the time, but it should be appropriately implemented to manage the exposure of nurses to those alarms. And this is one way of doing that. Okay, so I think this is close to being the end. So there's been a lot of discussion of AI over the morning, and there will be continue to be during the rest of the conference. And I wanted to say a couple things. So in our failure to rescue work, what we found was that there's a lot of emphasis on scores to find certain things. There's a sepsis score, and we found that physicians that perform certain types of surgeries like orthopedic surgery and a few others have scores specific to their patients. And so we think that that is a dangerous place to go. And what we just saw in the EPIC deterioration score is a view of a general deterioration. Something's going on with that patient. And we would tend to agree with that way of thinking about things. So moving from the general to specific, and AI or pattern recognition acting as a guide and a recommender, or helping people to draw attention to certain things rather than it being a decision maker. So really in a decision support and not necessarily in a highly automated way. And here's an example, and even though this is for a specific condition, this is a study that we did to look at patterns for pulseless electrical activity. So after we had realized that we had eliminated deaths from opioid-related overdoses, PEA was our next highest cause for rescue that was listed in our rescue database. So we went after this. And we looked at two things. One is trends in the mean and trends in variability. So you cannot get any more simple than this in terms of data analysis. This is not complicated at all. And yet we can see in these charts, so I think that these are 5-minute increments leading up to a PEA event. And you can see those trends start to increase over time. And we were able to look at those trends and write up a staged way of thinking about this. So, hey, you have a patient that has these characteristics, they're more likely to have a PEA. Second one is, well, you've got a patient that has some changes in variability in their parameters, so you should be maybe watchful waiting with this patient. And in the part 3, about 20 minutes before an impending PEA, you might see this pattern. And if you do, we might want to implement an alert that brings somebody to a bedside. So this is simple, and it meets a lot of the criteria that Michael just mentioned, right? So transparency, being able to peel back the covers, you can justify things, and it doesn't necessarily tell somebody what to do, and that, I think, would be decided by a group of clinicians determining the actions that are here. Same thing with news and muse and all these things. You can score somebody all you want all day long, but if people don't know how to respond appropriately, and if it's not an actionable request, then people are not going to use the information that you're giving them. So with that, I'll just summarize by saying that having multidisciplinary teams, including engineers, human factors engineers, nurses, physicians, all types of clinicians, work together to develop systems in a hospital rather than to implement technology is an absolute must. And the benefit of having a person like me at Dartmouth Hitchcock for the last million years is that we've been able to really take deep looks at this and make sure that our patients are safe, and we can keep improving the system for our nurses, who are the front line of detecting deteriorating patients at the bedside. And so I think that those points are really important related to AI or any other type of technology that you would implement at the bedside. So, thanks.